So I've been asked today to discuss the clinical implications of HIV resistance in direct-acting antiviral-based regimens. And I think the concept here is that HCV is not a homogeneous population of identical viral particles in infected patients, but behaves as a quasi-species, which is a complex mixture of genetically distinct but closely related variants. And in every infected patient, you have a major dominant viral population, which is the one that can be seen with simple methods for sequencing, the ones you may have in a virology lab. This is a major viral population. You have some intermediate viral populations, but you also have a very large number of minor viral populations, which are not detected by conventional techniques, but are very important because within these minor viral populations, you may have pre-existing variants that are resistant to various drugs, direct-acting antivirals, and will be the problem. So first of all, I would like to discuss the mechanisms of resistance based on this concept of quasi-species distribution of HCV viruses. And you have to understand that resistance is a very simple Darwinian-based concept. The patients at the beginning of therapy are infected by a major population, dominant population, of viruses that are sensitive to any drugs, but within the minor viral population, you have a small population you can see here in yellow, undetectable but present and replicating at low level that is resistant to the drug you're going to use. And if you administer the drug, which can be any inhibitor of viral replication, you will change the environment in which a virus replicates completely. This environment will become unfavorable to the sensitive virus, but will become very favorable to the resistant virus because the drug does not act on this virus. And what will happen is that the sensitive population will shrink. This virus will be profoundly inhibited. It will not be killed. It will still be there, replicating at very low level. And the resistant virus will expand and fill in the replication space to become the dominant virus. If you stop administration of the drug, you restore the pre-treatment environment, and in many cases you will be able to restore what was the phenotype and the genotype of the virus at the time, with the sensitive virus coming back as dominant viral population and the resistant virus being again a minor viral population. However, it's also possible that in some cases this resistant virus acquired some fitness and will remain present in larger amounts than before therapy. That's the concept of resistance. It's a general concept based on Darwinian concepts, and this is true for HIV, for hepatitis B, for hepatitis C as well. It's the general idea behind resistance. Pre-existence of minor viral populations are resistant, their selection, and their growth based on relative fitness. What about HIV resistance to different classes of direct-acting antivirals and host-targeted agents? We know. As you know, there are many direct-acting antivirals on the market, telaprevir, boceprevir, and in development, and there will be presentations on these. And they split into two big categories. The first one is the NS3-4A protease inhibitors, telaprevir, boceprevir, but many others. The other ones are different classes of drugs that all inhibit HCV replication, the synthesis of new HCV genomes. And these include the nucleoside and nucleotide analog inhibitors of the RNA polymerase, the non-nucleoside inhibitor of the RNA polymerase, the NS5A inhibitor. These three groups are direct-acting antiviral that target the virus, and there are also two classes of host-targeting agents. The first one are the cyclophilin inhibitors, and the second ones are antagonists of microRNA 122. All of these drugs have the same target, which is inhibiting viral replication. I would like to discuss issues related to resistance for each of these groups. The first group of drugs are the NS3-4A protease inhibitors, and you can see on this slide on the left a three-dimensional representation of the protease, which is the enzyme that catalyzes the synthesis of major viral proteins. And you see on the right a higher magnification of the catalytic site of the protease. And within this site, you can see this blue, white, and red. It's not the French flag. It's a molecule of telaprevir. And the mode of action of telaprevir is to bind directly, tightly into the catalytic site of the enzyme and block its function. And you understand very well that if there is any amino acid change within this catalytic site or close to this catalytic site, this will change the ability of the drug to bind into the catalytic site. And resistance is exactly this. The catalytic site has a mutation. It has a different amino acid, and the presence of this different amino acid changes the shape, and the molecule of inhibitor is no longer able to bind into this catalytic site, no longer able to catalyze to inhibit the catalysis of the protease function. So this slide shows you the 5 main amino acid substitutions that have been described to be associated with telaprevir or boceprevir resistance. There are 4 here which are very frequent at position 36, 54, 155, and 156. And the one at position 168 is not that frequent with telaprevir, boceprevir, more frequent with other protease inhibitors. And you see very well that all of these mutations are located very close to the catalytic site or within the catalytic site. It's what I said. When they are present, the inhibitor is no longer able to block this catalytic site. And the effect is the one you see here. You can see here at the top the placebo arm and 2 arms receiving telaprevir as a monotherapy. The drug is given alone. Initially, you have a sharp decline of our replication, which is the effect of the drug on the wild-type sensitive virus. But after a few days of administration, you see the viral load going up. It's not the same virus which is coming back. It is a resistant virus, which was undetectable, has been able to grow, filling the replication space, and causes this re-increase of viral replication. So it's a different virus, and here there has been a shift from a wild-type sensitive virus to a resistant virus, which grows and will, at the end, reach very high levels of replication. There are now second generations of protease inhibitors because learning from the mechanisms of protease inhibitor resistance has allowed some companies to develop second generation protease inhibitors. And the drug which is the leader for the second generation protease inhibitors is a Merck drug. It's called MK5172. And you can see here the levels of resistance conferred by mutations that are shown here. The mutations I mentioned, position 36, 54, 155, 156, etc. Boceprevir, high levels of resistance. This is a Gilead drug, GS9451, high levels of resistance. Cimeprevir here, lower levels of resistance, but still high for some mutations, especially 168 here. This is asunaprevir, the BMS protease inhibitor, still relatively high levels. All of these drugs are first-generation protease inhibitors, first wave, second wave. Here, MK5172 has virtually no resistance for most variants, except a little bit here for variants with mutation position 156. Second generation, better resistant profile, so this will be useful when we use them in the clinic. The second group of drugs I want to discuss are the nucleotide analog inhibitors of the HEV RNA polymerase. You will have, I think, a couple of presentations on these drugs. The leading drug in this group is sofosbuvir, the Gilead drug. And the mode of action of these drugs here is within the catalytic site of the enzyme. This time it's an RNA polymerase. And the nucleoside or the nucleotide analog is inserted in the RNA chain information. And this insertion blocks the formation of the chain. So the RNA, the viral RNA, which is in building, cannot be built any longer. It is stopped, and this blocks replication. There is resistance to this drug that has been described, and especially there is one mutation here within the catalytic site of the enzyme at position 282, which has been described to confer low-level resistance to the nucleoside or nucleotide analog that target this function. However, the viruses that bear this mutation are very poorly fit. This means that they are not able to replicate well, because this mutation alters their capacity to replicate. And therefore, even if the virus is selected, it is not able to grow. And this explains that the nucleotide analogs have a high barrier to resistance. It's not a high genetic barrier, because one mutation is enough to confer resistance, but if the virus does not replicate, the barrier is high, and this is one of the main characteristics of the nucleoside and nucleotide analogs. In contrast, non-nucleoside inhibitors of the RNA polymerase target the same enzyme, but this time no longer within the catalytic site. Their targets are allosteric sites located at the surface of the enzyme. There are 4 sites that have been described, A, B, C, and D, with different classes of drugs that target them. And one of the main characteristics of these drugs is that they have a very low barrier to resistance. There are many mutations that have been described, in general close to the area where they bind, for the same reasons I as I've said before, because if there is a mutation in the binding region, the drug is not able to bind any longer. And you can see here a description of the many mutations that have been identified in region A, B, C, and D that confer resistance and generally high-level resistance to these non-nucleoside inhibitors of HIV replication. And this is one example of a drug which is no longer developed, but the data was interesting. This drug was called filibuvir. It's targeting thumb domain 2 in the RNA polymerase, and mutation at position 423, very close to the binding site here, have been shown to confer high-level resistance to filibuvir and other drugs from this class that are binding in the same region. The third class of replication inhibitors are the inhibitors of the NS5A protein. This NS5A protein is not an enzyme. The mode of inhibition is not well known, but this enzyme is necessary for replication to occur under the control of the RNA-dependent RNA polymerase. And many mutations have been described within the sequence of the NS5A protein that confer resistance. But here, it's really interesting to see that in vitro, in the replicon system, mutation at position 31 or 93 of the NS5A protein confer relatively low-level resistance in vitro. This is low-level resistance. Whereas for genotype 1A, which is a different subtype, it's the same genotype. It's not that different, but it's a bit different. You can see that the levels of resistance conferred by similar mutations, position 28, 30, 31, 93, were extremely high, and this explains why daclatazvir, the leading drug in this class, and ledipasvir is another one, why these drugs generally have a high barrier to resistance for genotype 1B, but a low barrier to resistance for genotype 1A, and this will have an impact in therapy. There are second-generation NS5A inhibitors that are coming as well. One is developed by Killian, the other one by Merck. This is the Merck one, MK8742. And again, like for the protease inhibitors, you can see that these drugs have an improved resistant profile, at least in vitro, compared to daclatazvir, ledipasvir, that select mutations, especially at position 93 and 30. And these mutations confer high-level resistance. You can see here that the levels of resistance that are conferred are still detectable, but very low for the second-generation AS5A inhibitors. So you can learn from all what has been done with first-generation drugs and improve the resistance profiles of the second-generation drugs. These drugs I've described so far are drugs that are direct-acting antivirals. They target the virus. There are other drugs that target the host, and by definition, drugs that target host factors that are involved in HIV replication have a high barrier to resistance and do not select mutation. This is probably true, although with cyclophilin inhibitors, there have been a few mutations that have been described to be selected on treatment, especially this mutation here in the NS5A region at position 320. However, the levels of resistance that are conferred here in vitro are extremely low, and our experience of the use of cyclophilin inhibitors in practice, in real life, indicates that probably treatment failures are not due to selection of resistant viruses, but more due to low exposure related to pharmacological events. Finally, the last class of drug that is currently in development, although I'm not sure it has a great future because it's an injectable drug, are the antagonists of microRNA 122. This is the internal ribosome entry site of the virus. You have two regions here where this microRNA, which is abundant in hepatocytes, bind. And you can see here that if you block this binding by using the antagonist, which is shown here, there is inhibition of viral replication. This is efficient, this is potent, and has a very high barrier to resistance, and no resistance mutations at all have been described with this class of drugs. So if we summarize, there are different classes of drugs. Some of them have a low barrier to resistance. This means that they can select very easily for resistant viruses if they are used alone as monotherapies. This includes the first-generation protease inhibitors, the non-nucleoside inhibitors of the RNA-dependent RNA polymerase, and for the NS5A inhibitors, only the case of subtype 1A. These drugs are good anyway. The fact that they have a low barrier to resistance just indicates that it should not be used alone, but they can be used very confidently in a combination. I will come to this in the last part of my presentation. The other group of drugs are the drugs with a high barrier to resistance. These drugs hardly select for resistant viruses, and they include the nucleoside and nucleotide analogs, the cyclophilin inhibitors, the microRNA 122 antagonists, NS5A inhibitors for subtypes other than 1A, and second and third generation protease and NS5A inhibitors that will be coming very soon and replace the first generation of protease and NS5A inhibitors. How should we use this understanding, this knowledge, in our understanding of treatment failure? Well, you know that there are several treatment options. What we're currently doing and what is arriving here in your area is a triple therapy with peginterferon, ribavirin, and a protease inhibitor, which is a drug with a low barrier to resistance. We can also envisage for the future having triple therapies with peginterferon, ribavirin, and one drug with a high barrier to resistance. Eventually, quadruple therapy with peginterferon, ribavirin, and two direct-acting antivirals. And finally, the end of the HIV story will probably be the use of all oral interferon-free regimens, just using oral inhibitors of the viral life cycle without any interferon. And we'll discuss treatment failure and the role of resistant treatment failure in these four options. Triple combination with peginterferon, ribavirin, and one DAA or host-targeted agent. In that case, the sustained virological response strongly depends on the patient responsiveness to interferon. And this is a major driver. And I think if you think about treatment failure in the context of triple therapy with interferon, ribavirin, and telaprevir or boceprevir, you really have to remember this slide, which is the most important one, which tells you that treatment failure, the patient who is not able to achieve a sustained virological response, is due to an inadequate response to peginterferon and ribavirin that results in the uncontrolled outgrowth of resistant HIV variants that are selected by the protease inhibitor. In other words, the cause for the reason for treatment failure is not resistance. Resistance happens anyway. If you give a protease inhibitor, I've shown you it's a low barrier, it will select the resistant virus. But the patients who will fail at the end are the patients in whom interferon and ribavirin is not able to take care of this resistant virus. And these are the patients who have a very weak response to interferon. The demonstration of this came from studies where a lead-in phase was used. And you can see here in green the two groups of patients who had a poor response to interferon during the lead-in phase. Interferon and ribavirin alone for 4 weeks. You assess the viral load decline. Less than 1 log at week 4. Weak response to interferon. Overall, when you add the protease inhibitor, the SVR rates are of the order of 30%. If you're a good responder to interferon, more than 1 log HIV RNA decrease with interferon and ribavirin alone, then you will have a very high rate of sustained virological response. So this clearly demonstrates that the main driver of treatment success is the ability of the patient to respond well to interferon, and we know that there are many factors that are involved in this. Genetic factors, IL-28B genotype, the genotype of the virus, of course, and additional factors such as cirrhosis, for instance, which is associated with a poor response to interferon and ribavirin. The same is true now. The other slide was on treatment-naive patients. This slide is in treatment-experienced patients, and you can see that the same is very true. Overall, the rate of response in patients who have a less than 1 log decrease is of the order of 30% with telaprevir and 82% for patients who are good responders, and you can see that the difference is very true. Whatever the prior treatment response, prior relapse 62 versus 94, partial response 56 versus 59, and the most striking results here are the difference in prior null responders. If you're a prior null responder and are not responding again to the simple administration of interferon ribavirin, your chance of achieving an SVR is only 15%. What happens when the patients fail? I said that the cause of failure is the poor interferon responsiveness, but the consequence of failure is at the end selection of viruses that are resistant to the protease inhibitor that have not been eliminated by interferon and ribavirin. And you can see here in patients who were included in the boceprevir trials that at the time of treatment failure, there were more treatment failures in genotype 1A, for which the barrier is lower than for genotype 1B. And most importantly, half of the patients approximately had a dominant resistant virus at the time of failure, and half of the patients had a dominant wild-type virus. And this does not mean in the patients who had a wild-type virus at the time of failure that I don't see the slides on my screen. Are these guys cutting my... Anyway. This doesn't mean that the resistant virus has not grown, but it's just not grown enough to be detectable by the simple methods we have. The reassuring data, however, are that after you stop treatment, the resistant virus goes down, and you can see here that within approximately 16 months after treatment is stopped, the resistant virus that represented a majority here, 72%, decreased and then disappeared. Okay, thank you. So this was true for telaprevir, and this is also true for boceprevir, and you can see here that after you stop treatment, after treatment failure, the proportion of viruses that are resistant with different mutations shown here is decreasing, and after approximately a year and a half to 2 years, the patients have no more resistant viruses detectable. And this is very reassuring. It means that the situation that was present before any therapy has been restored approximately 2 years after the end of treatment. The big question is, should we do HCV-resistant testing? Look for mutations in patients who are treated with interferon, ribavirin, and telaprevir, boceprevir. Prior to therapy, there is no indication for resistant testing at baseline. All patients should be considered as harboring minor viral population that are resistant to telaprevir and boceprevir. In case of treatment failures, there is not any indication for resistance either. The reason is that the protease inhibitor resistant viral population has been enriched in every patient, and the result of resistant testing will not give you any indication of what you should do. So please, if you see virologists who tell you you should test for resistance, don't do it. We don't do it routinely. We do it a lot for clinical research, clinical trial, cohort studies. This is interesting to document. But in your clinical practice, you do not need to sequence the virus before treatment, or in case of treatment failure, the results might be misleading. The second option is a triple therapy with a drug with a high barrier to resistance. In that case, the SVR is still dependent on the patient responsiveness to interferon, but less dependent. And the reason is that the fact that you have a high barrier to resistance, you can maintain viral suppression by the inhibitor, and doing so, you restore some interferon responsiveness in the patient. I will show you several triple combinations that will come in the very near future, 2014, 2015, at least in France, UK, Germany, and the United States. And just show you the results of this study, which is a triple combination of peg interferon, ribavirin, and sofosbuvir, a nucleotide analog with a high barrier to resistance. You see here that the results are much higher. 90% of the patients achieved an SVR here, and the lower failure rate is due to the fact that the interferon response has been improved by a sustained inhibition of the virus, and the patients who failed on treatment did not fail because of any selection of resistant viruses, because I told you before that this drug selects for viruses that are very poorly fit and do not replicate and are not able to lead to high levels of replication. A third option is a quadruple combination with peg interferon, ribavirin, and 2 direct-acting antivirals. In that case, it's exactly the same. The SVR is modestly dependent on the patient responsiveness. The reason is the same. If you use 2 drugs together, you improve the barrier to resistance, you prevent the emergence of resistant viruses, you maintain virus suppression enough for the patient to restore his response to interferon and be able to control the virus. And there have been several presentations showing here at the bottom that if you use a quadruple combination, interferon, ribavirin, and NS5A inhibitor and a protease inhibitor, you have a very good response, whereas if you don't use interferon, ribavirin at the top, many patients have a breakthrough. And another study with the same combination, the claptasvir, naprevir, interferon, ribavirin, that shows very high SVR rates. In that case, treatment failure is very rare, and resistance does not appear to play any major role. I would like to finish now with what will probably happen with all oral interferon-free regimens. You know that all oral interferon-free regimens, by definition, do not use interferon. Therefore, the response at the end is not dependent on the patient response to interferon. It depends on the potency of the drug and the barrier to resistance of the combination. And if we try to make things very schematic, when you treat patients, it's very easy to achieve an SVR, theoretically. You must block virus replication. This is due to the potency of the drugs, and we've seen that there are many drugs. You must sustain this inhibition of viral replication. This means no resistance. You have to choose very well the combination of drugs you're going to use. And then if you do this, and just this, there will be a second slope of viral decline. The host will be able to eliminate the infected cells one after the other. And if you eliminate the cells and treat for sufficient duration, at the end you will have cleared all infected cells and the patient will be cured. So the choice of the drugs you're using and the potency and the barrier to resistance of the combination is very high, must be very high, and this choice is very important. I will show you some examples. This is an early study that has been done with a protease inhibitor, low barrier to resistance, a non-nucleoside, low barrier to resistance, and you could see that when combining these two drugs that were not very potent, the patient responded, but then broke through, and all patients had the viral load coming back with resistant viruses. This combination is not good. Two drugs with low barrier to resistance together, it's not enough, and you select viruses that are resistant to both drugs. So this is not a good option. Now, if you use two drugs, including one drug with a low barrier to resistance, this is a protease inhibitor, danopravir, and a nucleoside analog with a high barrier to resistance, you can see here that the patients do not have breakthroughs on treatment. They respond with a first phase decline, a second phase decline. So this is, in theory, a good combination. The barrier to resistance of the combination is high because you have one drug with a high barrier in the combination. Other example, combination of an NS5A inhibitor, daclatazvir, and a protease inhibitor, sunaprevir. These two drugs have a low barrier to resistance for genotype 1A, and you can see here that most patients on treatment had a breakthrough and selected viruses that were resistant to both drugs with the mutations present in the two regions in the same viral strains. Now, if you use the very same combination of drugs, daclatazvir and sunaprevir, in a different patient population, genotype 1B, in that case, daclatazvir has a high barrier to resistance. You have a high barrier to resistance overall of the combination, and all patients respond with a first phase decline, a rapid second phase decline, undetectable on treatment, no breakthrough, no relapse, and sustained virological response. You understand that the choice of the combination is very important, and if you combine three drugs this time, and these are the results of the AbbVie trial, three drugs with theoretically a low barrier to resistance, you can see that you can compensate. Two drugs with a low barrier was not enough, but three drugs with potency and a low barrier can make it. The three drugs are ABT450, it's a protease inhibitor, which is boosted by ritonavir, ABT267, that's an NS5A inhibitor, and ABT333, a non-nuc. The three drugs together, they can achieve SVR rate of the order of almost 100% when used together in patients infected with genotype 1, and also very high SVR rates in prior non-responders, here 93% when the three drugs were used together. So this brings me to my conclusion, and as you hopefully understood, DAAs select HEV variants with reduced susceptibility to the drug, which we call resistant HEV variants. The different classes of direct-acting antivirals have different barriers to resistance, and they're associated with different resistant profiles, which I've described. In combination with peginterferon and ribavirin, the cause of treatment failure is the inadequate response to interferon that then favors the outgrowth of DAA-resistant HEV variants. And in the absence of interferon, resistance will be the main cause of treatment failure eventually, although this will not happen often with these good therapies, but it can be prevented by using combinations of potent drugs with a high barrier to resistance, and we'll see more data presented very soon in this meeting. And finally, I would like to thank you very much for your attention.